It's in the, she already put it on the blackboard. It's already on blackboard. Yeah.
When did she put it on?
Now you're whispering.
No,
She did put it on?
Yeah.
No worries. No. I just want to make sure everyone had access to it first. So that being said, does everyone have access to the PowerPoint?
Yes.
Yes.
It's on blackboard. Definitely.
All right, good.
Definitely.
Everybody got the recording devices taken care of? I see the 3-view camera over there too.
Ready.
So, all right. Good morning, everybody.
Morning.
And how y'all doing today?
Good.
Good. So, firstly, definitely want to say congrats to you guys. You guys are about to be P4s.
That's
So,
right.
you back on says, picture on the back real quick. So, you're not rising, you're P4s. Therefore, in my book means you got a pharmacist. So, as like, that's just think it that way. So, same response I give to my students, but it's like, you're a pharmacist. I was like, really? All right, cool. I can receive it. Can I get pharmacist money too? I was like, nah, you still get paper free. But yeah, I know this is the last time you guys we talked together. That was from last semester in these courses. How did it go with the questions? Y'all remember?
It was
Hey, like,
alright.
I get all right. I get like a heck no, and I feel like it was cool. It's alright. Okay. All right, man. In between, okay. So I'm getting solid stuff. Okay. Well, you guys know since I'm a TC grad, you know how we roll. So you guys will get, we will have a, how Dr. Mo said, AOC. So keep it that way.
Yes.
Okay. So that being said, then for those that remember me, my name is Dr. Carfor. I'm one of the Trent Care pharmacists over at Houston Methodist Willowbrook. Look, catch the jacket, of course. So, that being said, we're actually going to talk about pulmonary artery hypertension. Now, just to give you guys a disclaimer, this is a very specialized disease state, very rare. You don't see it happen too often. I ain't for myself, practiced over 8 years. I'll probably see this. I only see a patient have this maybe 8 times. I want to say, and out of 8 times or more so history, more so actually treating it actually from there. So with that, we're going to talk a lot of detail about that. That way, by the time we're done with this presentation, that you guys will be able to recognize it, able to manage it as a part standpoint. Fine. I won't say you gotta be specialists, but you guys will just see a patient with your age. Okay then. So, all right. All right. Now, for our objectives for this lecture today is to define, firstly, pulmonary hypertension, also known as PH. You're going to see a lot happening here because a lot of things play in. And briefly introduce different groups, especially with pulmonary hypertension, including PH, will be our focus for today. And we're also going to discuss what the prevalence, pathophysiology, and genetic causes of pulmonary artery hypertension, also known as PAH. And next, we'll also recognize signs and symptoms of PAH, including the clinical presentation and appropriate diagnostic criteria. And lastly, we're going to discuss in detail recommended treatment options for PAH, including side effect, drug interaction management, and monitoring. All right, so firstly, what is pulmonary hypertension? So that is dealing with high blood pressure that specifically affects your pulmonary arteries, lungs in this case, as well as the right side of the heart. Note that the general cause is almost always due to increased pulmonary vascular resistance, or PVR. Know that PH is a major global health issue that affects all age groups, And note that the prevalence is higher in individuals aged greater than 65, or in other words, our geriatric population, with pre-existing pulmonary and coronary issues. So that would be patients who may have COPD, for example, emphysema, as well as our heart failure patients, which we're very much so accustomed to already. Note that just affect at least 1% of the global population as a whole. And note that PH specifically, this global prevalence is about 48 to 55 cases per million people. So that explains how rare this is on that end. Now, also know that right ventricular RV, in this case, heart failure is a complication of PH. And as we talk about this, we're going to explain how to do that and how we prevent that from actually getting to that phase. Since usually the mortality happens in these patients usually fall into that group. Now, so these are actually the 5 groups that are associated with pulmonary hypertension. There are the subtypes of pulmonary hypertension. So our first one is our PAH, our pulmonary artery hypertension. Our second group is our pulmonary hypertension associated with left heart disease, heart failure, for example. Group 3 is your pulmonary hypertension associated with lung disease and/or hypoxia, which is COPD that I gave an example earlier. Group 4, which is your chronic thromboembolic pulmonary hypertension, also known as CTEP, which is more of a thromboembolic state that is completely managed on how we treat them using anticoagulation on that end. And lastly is our group 5, which is our pulmonary hypertension with unclear or multifactorial mechanisms. However, so there's a lot of groups right there. The only one we're focusing on is PAH. All right, so with our pathos we're going to talk about today for PAH. So what I want to point to real quick, if I can pull this cursor here. All right, good deal. So right here, if you look right here for the pulmonary artery and the vascular obstruction, your for a normal pulmonary artery for everyone is usually like this. But with PAH, it looks like this. So you see, this pretty much closed up at that standpoint. Now, there's different mechanisms of how that happens, which goes into our pulmonary vasculopathy right here. So one way is due to like proliferation or fibrosis. So that artery is actually building cells that's causing it to close up like that. Then you have the vascular remodeling, where the arteries are most actually circling around the arteries and actually closing up on that standpoint, creating pressure, as well as the lesions that can come into as well, that can cause the closing of those arteries. And also with the pressures being pulmonary hypertension, is causing damage to those arteries, which cause the healing process, which also leads to the thrombosis formation, which will cause the closing of those arteries too. And of course, vasoconstriction, of course, because it's actually closing into as well. And that can lead to that vascular obstruction that I was talking about here too as well. And as you see right here, right heart failure, which I explained earlier, that's your complication in regards to PAH at that point, which you will see the right ventricular remodeling, or if you think about back when heart failure, when you guys had it, it's more talking about the cardiac muscles remodeling itself because it's trying to have the pump better. So there was building an extra muscle, which much you would like to work out, have muscle skeletal, you don't want that for your heart. And that's what leads to our heart failure point due to that increased pulmonary vascular resistance that we're talking about too as well. As well as dysfunction is happening at that right ventricle too. And right here for our current therapeutic targets, we'll talk more in detail when we get to the treatment section of the slides. So that will include areas such as your endothelial pathway, as well as your NO, SGC, CGMP pathway, as well as your prostacyclin pathway as well. And we'll talk about how each pathway will actually play a part in managing these patients and treating them too as well. All right, now for clinical presentation of PAH. So on the left figure I have right here, this actually talks about the symptoms, whereas the right talks about the signs on that point. So this is actually a little bit broad, but I'll tell you what's actually referred to for PAH at this point. So on the left figure, it goes from your early to late symptoms. Early symptoms, we'll start out seeing the dyspnea on exertion, as well as dyspnea when bending forward, which we call bendopnea. You also see the fatigue and rapid exhaustion, which tends to happen with patients when they're just doing ordinary activity or ordinary physical activity, which we'll talk about when we start classifying PAH too as well. Also the palpitation or heart racing on that point too as well. Hemoptysis, as well as your exercise-induced abdominal distension and nausea. And then you also will see weight gain due to fluid retention. So you see we talk about late stages, so now we're getting closer to the right heart failure symptoms we're talking about. And also syncope, which can happen during or shortly after physical exertion as well. Now, like there's a rare thing that's happening with PAH in particular. That will actually include the external chest pain that tends due to stress, as well as hoarseness as well, and shortness of breath, wheezing, and you see there too also lower respiratory tract infections and pneumonia at that standpoint. So like, here's the thing is when you see these patients come to the hospital, if you look at their past admissions, if you see that you just have an element of pneumonia every single time and they keep coming with the same symptoms at that point, that's actually a risk factor where you probably have to look to see if this patient also has PAH that's actually putting them at risk for that. Now, on the second figure, which on the right hand side here, so on the signs of PH, you will definitely see cyanosis for sure. You also will see the systolic murmur, the tricuspid regurgitation, as well as the diastolic murmur of your pulmonary regurgitation as well. And I'll say for right here, for the signs pointing towards underlying cause of PH, I will be concerned about this area because it's more so to do with the other groups. So we're not focused on that. However, the part I want to point out to is the signs of the right ventricular backwards failure and signs of the RV forward failure. So, signs of backwards failure, to give us an understanding between backward versus forward. So when we're thinking about backwards failure, we're talking about pulmonary congestion at this point. We're talking about fluid buildup that's coming in the arteries, pushed right back into the vasculature. So that's why you see example of the distended pulsating jugular veins, therefore that blood you pull right into the right side of the heart. You see that abdominal distension too as well. You also see the ascites as well. The third space in the fluid in the abdomen was hepatomegaly associated with the ascites, and also you see pulmonary edema as well, showing those signs of backwards failure. However, when you see signs of RV forward failure, so that's where the right ventricle is not able to pump blood into the pulmonary arteries, which gets to the lungs. So with that, if it's not able to pump blood to the arteries, well, guess what happens? Your lungs are going to oxygenate the blood to get to your left side, right? So when if they can't do that, that's when you're not getting not only getting enough blood pumping to your left side, how we get to the rest of the body, but also you're not getting enough oxygen either. So that's when you start seeing the distended. You also will see the cyanosis, which we talk about the blue lips as well as the blue fingertips, because less oxygen there, so you got able to see that too as well. Well, showing signs of hypoxia from that end, as well as dizziness, as well as see a pale complexion, as well as cool extremities, as well as a prolonged calorific, which is all talking about hyperperfusion at that point. So that'll be a good way to help explain you guys the difference between backwards and forward failure at that point.
Can you explain the difference again?
Yeah, between backwards and forward failure? Yeah. So backwards is where pretty much is that where the blood flow is coming from. Think of it this way. So let's everybody think about the heart for example. So with the blood flow, what's happening is when it's getting through that jugular vein, but it's not able, but what happens is backing up because because the pressure is so strong. So it's backing up back into the vasculature from the right artery. Yes. So with backing back into it, what's happening is you actually have a lot of fluid congestion coming back into it, leaking up for the vasculature. So when it's leaking in there, that's when you start seeing the pulmonary edema, because that fluid is being backed at that point. That's when you start seeing the fluid build up for the abdomen tube or the ascites as well. And that's also where you also start seeing as well to like the jugular vein, because that fluid being backed up back to your jugular vein. Because you remember the normal flow is usually jugular vein goes right to your right artery. So that backup is causing that jungle vein to expand, which you will see that from a backwards, so it's backwards, went backwards. But when you go to forward, what's happening is that during how your blood flow works, it'll go right to your right atrium, go right to your right ventricle at that point. So what's happening in that right ventricle is not able to pump that blood to your pulmonary arteries to your lungs. So if it's not able to pump there, that leaves a problem where, one, you're not getting oxygenated blood to your left side of the heart, where it's blood's getting from the lungs. And then it also will lead to affecting like the blood volume of being able to get the rest of the body. And that's when you start seeing that hypoxia, because if you have blood flow, not much of it, much more of it is more deoxygenated blood. So at that point, as we start seeing the bluish lips, bluish fingertips too as well, then there's like seeing the dizziness too as well as seeing like those cold strings because you're not getting enough blood flow, and as well as in that prolonged capillary fill. So that blood flow feels like if I'm pressing my fingertips, for example, you know how you see some blood flow come back pretty quickly. Well, in that situation for a forward failure, you want it to take a little long. It'll take longer to get that happening. Because you have the blood flow going because that right ventricle is not pumping hard enough to do so. But I hope that helped explain it.
Yeah.
All right. Good. All right, cool. I'll make sure you guys understand that part so when we get into the medications that y'all see, oh, I see how this works at that point. Okay, so this is actually the WHO classification for PAH, and it's broken down to 4 different classes. And this would be hint, a good way to know this too as well, because this actually will explain like the different classes and how we, based on FC class or functional class, that each PAH patient will belong to, and that will determine what kind of treatment we'll give them to as well. So our class 1 will be patient with PAH who do not limit physical activity or result in symptoms of dyspnea. So these patients are the ones who are pretty much asymptomatic. They have pulmonary hypertension, but they'll walk around you and me why they need issues at that point. And then you have your class 2, which is your patient with PAH with slight limitation in physical activity, but they aren't comfortable at rest. And they usually have those symptoms such as dyspnea, fatigue as well, the chest pain, or the near syncope during. Usually happens during the ordinary physical activity. So a good way we talk about example is going from the couch to the bathroom as an ordinary physical activity for anybody. So your class, think of this, well, we can use that as an example to help you guys understand that. So class 1, the patient is able to move from their couch, go to the bathroom without any issues, but they still have pulmonary hypertension based on what they saw. Then your class 2, same scenario. When they get up from their couch and go to the bathroom, they do feel a little bit tired, but they still make it without much difficulty at that point. And that tired can be the fatigue, or they may feel a little short of breath on that standpoint as well, or you feel a little bit of chest pressure that's going to the bathroom. But it's very limited. But they're coming to rest too. They don't have any issues or symptoms on that point. However, when we get to class 3, so class 3 is where we're talking about the same thing. They're going from the couch, going to the bathroom as well. But this time, as they're getting up, they really start feeling weak. They start feeling short of breath. They start being pretty tired. Where there's some difficulty trying to get there from the transit from the couch to the bathroom at that point. Right. So and so at that point, it's more severe at that point. But they're still comfortable at rest though. Then lastly, you have your group 4, your class 4 or your FC4. Now this situation is where they can't get off the couch. So they can't get off the couch, they can't get to the bathroom at that point without feeling any type of symptom, and it's pretty severe. And they're all unable to complete that activity at all. And even when they're resting, they're still having that same symptoms as well. So it's 24/7 pretty much. And unfortunately, these patients with class 4 are the ones who also have right heart failure too as well. Hence the reason why they can't really move around as much. So, so with these patients, even with any type of physical activity, will cause some level of symptoms that will happen. So unfortunately, these are more so your patients who are at the end stage of this disease at this point. Okay, so this is actually our diagnostic test that you use for PAH. And for you guys, there's more so of like, we're pharmacists, not physicians, so we're not gonna be diagnosing anybody. But it'd be good for you guys to understand it too, so when y'all see that, y'all know where it was coming from. So first we have our echo, which can be done, on an inpatient or outpatient. And this is where you usually detect and monitor for like that right ventricular function to see that pulmonary overload if it's there, as well as the calculating your mean pulmonary arterial pressure or your impact, which is caused by PAH at that point. And that'll be a part of that diastolic criteria we'll talk about in the next slide. Next, we also have our EKG, which is used to detect the RV hypertrophy as well as the RV strain as well, which the RV strain you see because of that right heart failure not point to as well, so that will detect that. We also have our 6-minute walk test, also known as 6MWT, which is used to measure exercise capacity when walking at a normal pace. So that's why I was using the tracing the couch from the bathroom example, because I mean it's a little more mild, but that's a good way to explain from layman's terms. So this test is actually not just used for PAH, but used for other patients too as well. So a good example is like, for example, for a COPD patient that came in with COPD exacerbation, and we find out in the hospital they need oxygen to go home on that. Well, usually for us to make sure they need oxygen, we should do this test just to make sure to see if they actually qualify for it too. So like this is actually pretty inexpensive. It can be done inpatient or outpatient as well. And this will be a quick understanding of how well they tolerate doing a normal pace at that time before they start feeling the symptoms, such as that shortness of breath or the fatigue at that standpoint too as well. Note that the therapeutic goal in PAH is at least 380 to 440 meters in 6 minutes too as well. So that's what we'll look at when they usually evaluate the patient and also monitor as far as improvement. Then we have some genetics. Know that the presence of the BMPR2 gene, that gene has a mutation in that gene. This leads to a 20% lifetime risk in developing PAH. And the way how we will actually monitor for that for these patients is to pretty much do a yearly echo for the ones who are asymptomatic and for positive carriers. So an example of this being like, let's say a mother of 3, and she got diagnosed with PAH at this point at the clinic. Their next step will be to actually start testing the children. So they're going to we'll test her and see if this is actually was genetic at this point. And if it was, now they're going to test the kids too. And the kids do have the carrier, but they have no symptoms. Well, those kids also going to start getting echoes every year, just to monitor closely, because the disease today is all about the progression at that point. And the earlier you catch it, the better. And also too, I forgot to mention too, is the EKG can be done inpatient or outpatient as well, along with your 6-minute walk test and your echo. All right, now we have our pulmonary function test and your arterial blood gas, or ABG. Know that your PFTs, in other words, is used to detect your low lung diffusion capacity for carbon monoxide, which is your DLCO. So I'm pretty sure, how many of you guys know what DLCO is? All right, I think that you guys don't know yet. It's okay, I'll explain to you guys. So DLCO is pretty much you're measuring how much oxygen your lungs are able to translate into the blood. So like the higher the better. That means that your lungs are able to transmit oxygen to the bloodstream that gets the oxygen rest of the organs in the body. So usually for PAH, it's usually normal to slightly low, which is 50 to 74%. And normal DLCO is usually greater than 75. Then you also have your ABGs, which detect your PaO2, which is your partial pressure of arterial oxygen. And it's usually normal or slightly low as well, which is about 75 to 89, around that range. Normal PaO2 is usually between 80 to 100%. Sorry, 80 to 100, sorry. So, physical signs of low readings, which include shallow breathing, as well as slow breathing too as well. Well, so if you start, if this was seen on a patient, let's say they actually had a DLCO of like 55. All right, we'll see that with their breathing on step where people are shallow. They also definitely will see a shortness of breath too as well. So you can see that from a clinical standpoint. And then we also have our right heart catheterization, our right heart cath. This is actually the gold standard in diagnosing and classifying PAH. So with that, know that an MPAP of greater than 20, as well as a pulmonary capillary wedge pressure, PCWP, of 15 or less at rest, generally is indicative of PAH. So like with PCWP, I will say with this slide and particularly with these three tests, these tests you typically want to see more so unless you're more into the internal medicine side and more so really into critical care at that point. That's why it's kind of like maybe a little bit foreign on that end. So with the PCWP, that was measuring pretty much the pressure that's coming from the left atrium of the heart at that point. So if let's say your normal is usually between 4 to 12. Now for example, let's say it was less than 4, that means they're not getting much blood flow, and which can lead to hypovolemia, which usually when fluids are being used at that point, they help manage that. But these patients were not with pulmonary hypertension. We're not concerned about hypovolemia because that's not the case for them. However, if this actually was greater than 15, at that point, what's telling us is that pressure is actually a compensatory mechanism for your left ventricle, because what's happening is that your left ventricle is failing because it's not able to pump the blood flow into the rest of the body. So it's failing. What's your body normally do? Compensate. It will just try to fix it on its own. So what happens is that pressure that PCWP, it will actually increase because now the right side is trying to help the left side out. So now pumping extra blood through the lungs into the left ventricle to help it to pump better. But what's happening is that it's not helping. So with all that extra volume, that causes that leakage to the lungs, which causes that pulmonary edema too as well. So like you see how it's starting to look like heart failure right now. We're talking about. So that's what usually happens in that case too. So that's why it's important to measure these two, because that will tell us what type of disease that we're dealing with. In this case, for PAH. You guys have any questions about that process?
No.
Huh? Only ask because depending on how your cardiology lecture is pathos is extremely important on that point. So I want to make sure you guys understand why we do these medications at this point, so you guys know how we're taking care of the patient on that. All right. Now we also have your X-ray that we use for diagnostic purposes, and I'll say just pay attention more so to here for the signs of PH and abnormalities. Know that patients with PH usually have abnormal findings such as the right heart and pulmonary artery enlargement. That's pretty much all you guys already know, need to be aware about as far as for PH on that point. However, know that normal X-ray does not exclude the patient from actually having PH. As a matter of fact, with an X-ray, you usually see this with more so patients who are actually more of class 4 or maybe having maybe also showing signs of right heart failure, where it can be identified simply through X-ray versus doing a more invasive imaging. Okay, now we go to treatment now. All right, so you guys are familiar, as you do. I always like, before we start talking about treatment, I also want to know is like, what is my role as a pharmacist in this disease? So, firstly, one role of the pharmacist that you guys want to be aware about, and I'll actually start this slide because this will be helping you get a better understanding how to answer my questions too as well. And this is where the evaluation of pH. So what I mean by that, that is to see which type of pH does this patient belong to. And that actually will help us to identify the indication and guide therapy based on the rationale of use. So a small example of this is doing invasive active testing for a patient who has a diagnosis of pH, to see if they can actually use calcium blockers based off that result of that test. So like, this is actually very important because if we don't know what we're treated for, how can we guide therapy on that end? It's not something about safety, also got to make sure of efficacy too as well. Now, also know that there's currently no cure for pH. Now, the current treatments are just to slow down the disease progression, and as well as improving the patient's quality of life, which is actually the sad part about this disease is that we're just trying to slow down the progression as much as we can, even halt it if we can, as well as make sure that quality of life is good too as well. Now, next thing I'll give to as well is knowledge of how to manage drug-induced pH versus idiopathic or hetero pH, which I'll explain to you guys an example of that in our next few slides. Now, of course, I'll be remiss if we don't talk about, we'll make sure that the medication is a favorable side effect profile based on the patient. Drug to drug as well as drug disease interactions are very important too as well. And you guys see here, I put in red with the exclamation marks here. Medication compliance is huge. Now, the reason why I say that is because that actually will greatly contribute to their pH improvement, as well as slowing disease progression, as well as improving those symptoms, as well as improving their exercise capacity. So the way I can approach this way is, like if they're missing doses for unknown reasons at that point, or they can't afford it, which we'll talk about next. What's happening is now that disease starting to progress, so they start seeing more of those symptoms at that point, and then started bumping down from, let's say they were a FC2 or a functional class 2, now they're going down to 3. Then they're going to 4, all because they're not taking their medications. So as pharmacists, compliance is key for them too as well. Now, we'll also put in red, cost, and cost, period. Reason why for that is because like, these medications are very expensive. I'm talking like, I'll say with the ERAs we'll talk about later on, they're about, I want to say just for a 30 supply, they're a couple $1,000s on its own. And with those, you usually have your copay cards, of course, insurance is very important, unfortunately too as well. So like with that, even with those copay cards, it's still gonna be pretty expensive. You have those patient assistance programs where they will pay for it on their own, but usually only last for a year. So like these patients are gonna have pH for the rest of their life. So it's a very costly disease on this end too as well. And that will also contribute to medication compliance as well, as I mentioned earlier. The good news is, and this is why that vasoreactive testing was important, calcium blockers are currently your most affordable medication class. Now, know that too as well, that for the cost standpoint, is that they also greatly affect mortality and morbidity. So it's going back to what I was talking about with the compliance. If they're not compliant, mortality goes up, morbidity goes up too as well, quality of life goes down, and so forth from that end.
So even though that TCBs are the most affordable, are they the best? Are they considered like the best to treat the patient, or just more affordable?
So from an affordability standpoint, I'll put it this way, I think as a pharmacist, for me, if I'm looking at a patient who came with PEH as a diagnosis, and we're trying to measure therapy in the hospital setting, it was initially from that standpoint, my first thought says like, what kind of mission will we give to them is actually compliant for them. And what compliant I'm talking about is a cyber profile safe for them. First off, is it gonna work for them from rational use? And then lastly too as well is, will they be able to afford it? Because I had to think about not just for a month, like for a remission step, but I gotta think about for the rest of their life. So like if they will use calcium blockers, by all means, I'm gonna shoot for them first. Now also depending on what type of functional class they belong to, I may not be able to use them based off what they place onto based off the diagnosis. So that's another thing I had to look into as well. So we caught it early, and they had to be a candidate for calcium blockers. Oh, I'm gonna shoot that first. And then from there you have, I want to say the other group would be your PDE5 inhibitors, which are a little more affordable compared to the other agents, but they're still cost quite a bit of money. Because remember, they're doing things every single month for the rest of their life. It's not like they just get antibiotics for a couple of weeks and that's it. So like, to answer your question though, is more, I think for example of rationale, think about a side effect profile. Once I check those two off, I said, next thing, can they afford it? Because all these three things will affect their compliance. And then of course, once I do that, you already know sponsors will be educated too as well. That's gonna be another thing to help wrap everything up though. So like, that's kind of like a quick and dirty from this slide here, what I was expect you guys to think about as a pharmacist too as well, looking at these patients. And really, this is kind of like how you want to think for any patient you look at. Because at the end of the day, we also want patients to be compliant. And if they're not compliant, what's the point of actually recommending what we're going to treat them with?
Excuse me. Is it all types of calcium channel blockers that you can use, or is it specific to one selective or selective?
So, I'm glad you asked that question. That's what we're going to talk about when we get to the calcium blockers. There are only 3 agents in that class that we use. That's based off the studies that have been done for this disease state. But I'm glad you asked that. We'll talk about that more in detail for sure. Right, so pH is usually broken down as three different types. That include idiopathic, means you don't know where it came from, it just happened. We'll also have your heritable, or HPAH, which is pretty much the genetic from that standpoint, which is we were talking earlier about that gene mutation, which is where that falls into. And you also have your drug toxin induced, which is your DTPAH as well, which is drug induced. Know that IPAH as well as your HPAH requires the same guideline directed management. However, DTPAH is a different treatment approach. So this kind of go back to that evaluation of how we manage that patient before we actually will start therapy. Now know that even if we do all the right things for this patient, we did everything we did as a pharmacist, everyone, the whole team does the right thing on the patient is compliant, and with the best treatments that we have, unfortunately the 5-year survival rate after PH diagnosis is around 40.8%, which is, we put this standpoint, we put together numbers. Like how I said about earlier in the presentation, like 40 to 55 patient cases per million people. So actually I'll make it more personal, think of it this way. I've seen 3 patients this year that actually had PAH. So out of those 3 patients, 1, 2 of them may not make it in the next 5 years. That's even us giving their best shot. We did everything we're supposed to do. We took care of them as much as we possibly can. They may not make that. So that's actually a very sobering thought to think about. Well, unfortunately, it does happen. I had patients actually pass away due to that reason for that standpoint. And actually, matter of fact, that makes she rest in peace. She actually passed away due to cost. And what made it worse for her situation was that she also didn't have papers either. So she didn't have insurance. So with that limited what we could use to treat her with. And unfortunately, when we tried to treat her, it became a point of what she can afford and not so much what will help her. because it was more so what can help her. She would probably be still alive right now, but because she didn't have the money and much of the resources that we had to help her, that was enough, and unfortunately she didn't make it. So with that, this is why I say this disease is very specialized, but it's also not one of these diseases say that the patient will live long with this. So that's why for us there's a lot of room for us to really help these patients out from the hand. So know that the current guidelines are used right now to treat these patients, so we give them their best shot. And these break these different drug classes, such as our prostacyclin pathway agonists, also known as the PRAs, your prostacyclin analogs, known as PAs, your endothelin receptor agonists, also known as ERAs, as well as our phosphodiesterase, our PDE5 inhibitors, and our calcium channel blockers, or CCBs. Now, so it's the next slide that check mark, what you guys know. So with that, after initiation of therapy, know that patients usually are followed at 6 weeks, then every 3 months for monitoring costs, efficacy, and safety. Now, how we actually would treat these patients from a approach standpoint is that we will actually increase the dose, or we change the frequency of a current medication, and or adding an addition of a second or third medication can be done during each follow-up visit or hospitalization at that point. Now, knowing that optimizing the improvement of exercise capacity, symptoms, functional class deterioration, so going from FC2 to 3 on the subtypes at that point, showing the deterioration, trying to slow that down or even halt it, and also slowing disease progression as well. Know that transitioning from one medication to another and adjusting the current regimen, like adjusting the dosage or the frequency due to the adverse events, can be done to improve their safety as well as to maintain their efficacy for that same medication. Now, also too, I will say that mark of a hemodynamic improvement is the patient achieving an MPAP less than 30, as well as a pulmonary vascular resistance, or PVR, of less than 4 units, also the WU. All right, so our first approach we'll talk about is our DTPAH. So management, of course, the drug induced, all we're gonna do is stop the offending agent, right? So that will result in showing a full reversal of that PEH or a partial reversal once that diagnosis is made. Now, even when we stop that offending agent, we still watch that patient closely over 3 or 4 months, usually by follow-up visits, to evaluate if pH-directed therapy is warranted. Now, this only applies to patients who fall into the fall with mild pH or the lowest profile, which is pretty much your FC1 for the WHO classification. So if they're FC1 on that end, and it was drug-induced PAH, and if we stop that agent, we just watch for the next. We'll end up watching them over 3 or 4 months to see, okay, did they fully improve? Was it full reversal? If it's full reversal, they won't need any medications. But unfortunately, if they're not in that case, then we do have to manage it by starting pH-directed therapy with those medications that we were briefly talking about earlier. Now, let's say we start the agent, and then the diagnosis for the PEH, the DTPEH, is FC2 to 4. Then we still have to start them on therapy too as well, because the disease has shown has got to a point where stopping agent is not enough, and now we have to treat them from that end. So this is actually a list of medications so far that can cause PEH. The most noble ones, I would say, divided by definite association, which will absolutely cause it. But it's possible means that maybe not, but studies have shown that these can cause it. I would say here, like for the Minorex, the Benfluorex, and the Dexpen, as well as the Floraflu, those 4 agents over there are actually discontinued from the market. They're actually weight loss drugs. So those actually discontinued, so I don't even want to worry about that because you're not gonna see that in practice. Now, rapeseed oil, you might see it because some people do actually use rapeseed oil on that, and toxic rapeseed oil is mainly they take too much consumption of that. Methamphetamines, we all know that I know the abuse potential for that, so that can actually lead to PEH as well. And then on the possible association right here too as well. This is where I would say for us, for those who are going to the oncology, if I think are going to oncology, this oncology or going to more to the specialty side. These agents you'll see more so, and that's something you will monitor for too as well because they can lead to PEH if they're having those symptoms too as well. I think one thing that I think from a retail standpoint and community too as well that can be seen is that St. John's wort. Believe it or not, I still occasionally still want to visually he's still using it for some reason. And among the other reasons why we want to use St. John's wort already, as an reason why we don't want to use it for that side patients as well. But I will say though, for this slide here from you guys, from a knowledge-based standpoint, my like the questions that I have for you guys, it would be like I don't think I have a question for you guys on this here. No, I don't think I do. But I'll say for the best way to take from this slide though is pretty much have a general understanding of that these medications can cause pH and how we will manage it from that standpoint. All right, so now treatment guidelines for pH. That will actually include our classification that we talked about earlier. So we'll start with the acute vasoreactive positive. So the vasoreactive test that I was mentioning, that's what we do once a pH diagnosis is made to see if they're a responder or a non-responder to calcium blocker. So that calcium responds to calcium blocker therapy. And if they are, we're good. That means now we can actually start calcium blocker therapy or CCPs. Y'all see here it says high dose. And we'll go more in detail about that. So that's what we'll use. And the question you brought up earlier too as well on the agents, the ones that are being studied is the amlodipine, amphetamine, as well as diltiazem as well. Now, also too as well, our next section will be our treatment naive patients who have WHO FC1. These are your asymptomatic patients, generally speaking, but do have PH as a diagnosis. We just monitor them very closely now. And it will consider them based on what we see. Next, we have our FC2, or your treatment naive FC3 without the poor prognosis. FC3 is kind of is a bit interesting because FC3 depends on what their prognosis is. If they have a poor prognosis or no poor prognosis at that point, so that determines that too. So if they fall into that group, what we usually do, we can do a combination therapy, in which you'll see more so on FC3 versus 2, because that's more progressive. And that epicentin and tadalafil is like the study regimen that's been done, but you can interchange the classes within those same drugs. For example, instead of using tadalafil, I can use sildenafil in case, and instead it'll still get the same result. Same thing goes with epicentin, and instead of that one, I can use bosentan instead. On that point too, but the combination wasn't studied, but studies show you can still switch the class, switch the drug in that same class, and still get the result. Monotherapy, which you see more so for FC2 being done, that will include like your bosentan, your macetan, your epicentin, as well as the riociguat, as well as sildenafil or tadalafil. I also want to add here too as well that your calcium blockers also can be used for monotherapy as well for these patients too. It's not on here, but that's also included too. And that's something I would know that. So with that too as well, going on the next part will be our FC3 with evidence of poor prognosis. So these patients are also FC3, but their chances are to hit more to the mortality category that we're talking about. So these are the patients who begin their parenteral therapy, which will be the continuous IV esomeprazole as a protonol, as well as your case IV of the treprostinil or sub-Q infusion treprostinil. They also can use inhaled treprostinil in combination with a PDE5 inhibitor too as well, or a ERA, the endothelin receptor agonist too as well. So with that, I want to mention to like the generic medication here that wasn't on this chart, and that is Selexipag. That's actually that's an oral prostacyclin receptor agonist. So with that, that actually can be used for patients for class 2 to 3 being without poor prognosis. So the way you think this way, you'll be in that same group with the monotherapy for FC2 as well as F2 as well as FC3 without poor prognosis. And then we have next our FC4, which is patients are pretty much on parenteral therapy. So remember, these patients are the ones who they cannot move without having any type of symptoms, and they have signs of coronary right heart failure. So with those patients, they're definitely in the parenteral therapy that I just talked about, as well as the you know what, I just did something wrong here. So on FC3, I put the wrong part. FC3 with poor prognosis, the treprostinil, the inhaled oral, that falls into FC3 with poor prognosis. But FC4, that's what I was talking about, the combination with the inhaled treprostinil, with the combination with the PDE5 inhibitors, as well as the ERA. So I'll make sure I clean that up real quick. Now, PH patients with inadequate response to initial therapy, so alluding to what we talked about in the last slide, that is when we start adding narcolepsy PH therapy as well as adjustment of the dosage they're currently on if it's needed or is warranted or is possible. And then PH patients with FC3 and 4 with adequate response to the maximum pharmacotherapy. At that point, these are the ones that we max out everything. We try our best with these patients. These are the end-stage patients too as well. This is when we start thinking about lung transplant. As see if they're a candidate, and then we start thinking about palliative care, because at this point, their chance of them passing away is very much so imminent on that end. Just imagine the pH at that point. You guys have any questions about the slide? Good? All right, cool. I asked because I want you guys to know this. That's why I wanted you guys to make sure y'all know it. All right, cool.
So how do we make people strong?
So pretty much it's actually just no there. Let's say example, if you have a patient who has FC2, know that warrior option how to treat this patient. So that would be a question I would have on there. So I actually had 2 questions on there. Now I think about it.
What's that for questions?
y'all, okay, now y'all want to listen now. It's like, so with this slide, it's more we gotta know because so when you're treating PH, you want to know what the FC number is. So if FC 1, 2, 3, or 4, because as you see here, that will dictate what regimen you should be thinking about for this patient. So add to the fact of your calcium blockers, which are not here, but you're gonna have that down on your PowerPoint that can be used between FC 1 to 3, at 3 but without poor prognosis, and Selexipag can be used for FC 2 or 3 without poor prognosis as well. Knowing those 2 things that's outside of this slide, and knowing this slide too, will help a lot for the questions I'm about to give you guys. So, you guys good?
Yes.
Alright, cool. I'm trying to help you guys out here. Alright. Calcium channel blockers, or CCBs, these can be considered for all three types of pH, which would be your IPH, your HPH, as well as your DTPH. None of these patients, this is an error check mark here. None of these patients must be positive for a basic reactive test. before starting therapy, and are reevaluated every follow-up visit to ensure that there is a vasodilatory response there present. This is extremely important. And the reason why I say this is important, when I go into that dosage, you'll see what I'm talking about, is that with that pulmonary vasculature, a calcium blockage, we know that it does cause that vasodilation at that point. But if these patients are being responders to it versus non-responders, responders are typically about 20% chance of responders. So if they respond to it with how the disease state is, you want to make sure you have everything up front to help them out with. And let's say this patient doesn't have a test result, and they start calcium blocking this patient for that reason, with the dosage that's gene targeted for them, you really want to make sure that test is on board, because that can actually this can save a patient's life at that point. Rather, it's actually appropriate for them, and it helps slow down the disease state and help improve those symptoms, or it's not appropriate, and that can lead to those adverse effects that can actually put the patient 6 feet under too as well. So, like, with that being said, a negative result from a vasoreactive test and starting a CCB on this patient for this particular reason at those targeted dosages can lead to severe hypotension, syncope, and RV failure, unless it's prescribed by the standard dose for other indications such as hypertension. So, like, this is where I want to go a little bit and explain about this. So, with calcium channel blocker poisoning or toxicity at that point, where a patient, if they had a mental health issue at that point, and they took their whole third spine enveloping all at once, because they're trying to take themselves out, for example. So what happens is, so now we're going to photo level now. So you remember how your dihydropyridines and non-dihydropyridines, your dihydropyridines affect more the vasculature of your heart, while your non-dihydropyridines affect the myocardium, right? So your non-dihydropyridines being your diltiazem as well as your verapamil, versus your dihydropyridines dealing with amlodipine and phenidipine at that point. So what happens is that we know with diltiazem and verapamil, they call it that negative entropy, which is causing the decreased contractility, which actually can affect adversely for your heart failure patients at that point, with reducing depth compression, because that will actually worsen the symptoms, actually worsen the disease state at that point. However, they don't have much function on their vasculature, so they do for the blood pressure, not as much, because they affect more so the heart rate. While your dihydropyridines, which is your amlodipine and phenidipine, which are the two major medications in this class that we use for these patients, they're affecting the blood pressure in that standpoint. They're just lowering our blood pressure in that end. However, if we go with that concept of with the receptors and saturation and how much medication a patient is getting, if they're getting too much of it, enough is enough for it to leak off from the vasculature and get into the myocardium and start causing the same type of effects as the diltiazem and verapamil in that class, which can lead to that right ventricular failure at that point, because now you're affecting the cardiac output at that point, which is lowering that contractility, and that's actually causing both the ventricles to pretty much not work. So with that, this is important to know that too as well, though. And I will say this, that most pharmacists don't really know about this, because we never had to really think about that with the dosing for calcium blocker, because usually are pretty good at managing that. But in these patients, that's something we had to think about. But do you guys understand that process of how that works? Cool. So, know that your calcium blocker, just like I mentioned earlier, can be used as a first-line monotherapy in combination for FC 1 through 3, which is the 3 without poor prognosis. Know that once we know that the satisfactory response is not achieved, or if this clinical deterioration being seen while on that calcium blocker therapy, that despite having a positive test, we still checking every follow-up visit, then we need to start adding other agents of different classes on board to help manage the patient. So going back to that slide I was talking about earlier. Now, so let me ask you this. How many of you guys work in retail right now? let's get y'all a little shy about that. I'm like, okay. So, all right. So for those who are there right now, how often do you guys see amphetamine and given more than 60 milligrams twice a day on the prescription? Not that often? Okay. So in practice, you see more so in the hospital setting, you see those being ingredients to how to try to manage your hypertension, generally speaking, especially in end-stage renal patients. I'll give you an example. I actually had a physician of mine that I worked with over in the hospital. I think a week ago, matter of fact. Patient had end-stage renal disease. They were treating for hypertension at that point. They had no PAH at all. And they started the patient on 30 milligrams daily while in the hospital. And for the next 4 days, they were trying to send the patient home on 90 milligrams twice a day, which is actually the targeted dosage for amphetamine. Amphetamine in regards to PAH. And what happened was that, for those of you guys, I'm not sure how many of you guys may know, but for amphetamine, the max dose for hypertension, the extended release, is 120 milligrams a day, or 60 milligrams twice a day. Now, what I explained to him, because he was he knew about the syncope standpoint, but he didn't know about the RV failure that could happen because the patient didn't have PAH to begin with. And when I explained that part, I was like, oh shoot, I didn't know that. So that patient would actually ran the RV failure with them being on dialysis. That could push them more at risk due to what's going on in the heart. We already know the fluid is backed up, and we know how the function works from that standpoint. So the whole point I give that story is because that as pharmacists, right in a retail setting or in a hospital setting, I'm not a big fan of knowing the dosages for medications when it comes to teaching you guys. But in this area, it's extremely important for you guys, and something you guys know for this, for your questions too, is because that in practice, I guarantee you, probably within the first, I will put it further. During your rotation, you guys will run to it at some point. I guarantee you guys will run to it. It's like, oh yeah, I was sitting talking about that, talking about that, yeah, I remember that now. I'm gonna fix that, that's my intervention right there. So, this is very important to know this. So, with that, know that all of your targeted dosages are higher than the standard due to this disease state, because what's happening is that, it's causing systemic vasodilation. We try and give enough medication to that patient where it leaks over to your pulmonary vasculature to create that vasodilation that we're looking for, since they're positive or a responder to their vasoreactive test. So we have to titrate very, very slowly based on the response because we're going high dosage here. And these patients actually usually have a blood pressure journal at home with specific holding parameters due to that reason. So that we're going to monitor the tolerability as well as the hypertension episodes they may experience. Because that will determine if they tolerate it or not, or they tolerate fine, we can start just dosing them. So like this, so that's another part of pharmacists will be educating to how to use their journal effectively, how to manage that standpoint, what to do, and to as well. So amphetamine to the release, starting dose is 30 milligrams once a day. The maximum tolerated dose per day, which is where we want to get it to, if we can, is 180 milligrams. Know that we do not use the immediate release formulation due to risk of severe hypotension, because they work extremely fast, and that's a quick way the patient to come back in the hospital for that reason. If they were, let's say it was, actually, give you an example. For those who are in retail, if you guys get a family prescription come in, and let's say you have a family family members come in and say, yeah, my mom got diagnosed with this thing called, I think, pulmonary artery hypertension, something like that, some pulmonary high blood pressure. There's a red flag say, hey, we're looking at this amphetamine prescription. So I'm looking at this first, is it immediate release or is it extended release? If it's immediate release, that needs to be fixed. Because if they take it, this would be, lack of a better word, they won't make it. Because the blood is gonna drop extremely fast at that point. And another thing you probably look at too is that dosage we talked about earlier too as well. So you see how we're seeing how from a real-time practice how this will actually affect you guys, not only as pharmacists, but also currently you guys work as interns too as well, where you're working at as well. So our next one is amlodipine. So at low P, you tend to see more so because of the half-life that's pretty long. And note that the starting dose is 5 milligrams once a day. Note that the maximum target dose per day, which is what you want to aim for them, to get their targeted response that we'll like for these patients, is 15 to 30 milligrams. And to put in perspective, max dose for amlodipine for hypertension, which you normally see being used for, is 10 milligrams a day. So you see what I'm talking about being high dose and how this can be a difference for that, knowing if that diagnosis is there or not. Next, you have diltiazem, extended release, or your control release. Know that starting dose is 120 milligrams once a day. Know that your maximum target dose per day, which you want to get for these patients, is 720 milligrams. It's still pretty high too as well. And just like we're talking about amphetamine, we do not use the immediate release diltiazem because there's also a risk of severe hypotension as well. And actually the boot too as well. I'll say this also risk of hypertension and bradycardia. Since we're talking about myocardium from that standpoint with being a non-dietary period. So, any questions about the slide? So I want you guys to make sure you know this slide because that's something very important for you guys from a practice standpoint and also for you guys. Questions as well. All right, now we have our ERAs, our endothelin receptor agonists. Our 3 drugs in this class will include abraxantan, bosentan, and macitentan. Know that how it works is that you have your endothelin 1, your ER1, that usually binds to both your ERA, which is your endothelin receptor A, which leads to vasoconstriction of that pulmonary vasculature, or those smooth muscle cells. And then the same ER1 also binds to your endothelin receptor B, which is the ERB, which leads to vasodilation from the which will cover the nitric oxide and the prostacyclin production. Now, so ERAs, how they work is that they pretty much what they do is they block they end up blocking that receptor for the ERA and B, so promote the vasodilation. Now your warning is okay, you're blocking A and B, but you're blocking B that help with the dilation. But know that the receptor blocking potential for both of all the ERAs in this class, each one a little bit different, but they're all pretty much in the same group. The affinity is greater for your ERA versus ERB. So you're blocking more so the ERA that deals with the vasoconstriction and it was going through a normal pathway, and you're not messing with the ERB because that's actually going to be helping. And an ERB, really, that's from a normal person standpoint, the ERA, ERB are just helping with hemodynamic standpoint. This is maintain that process at that point. So, as P suggests, that's become dysregulated at that point. More so with the ERA, and that's why we target the ERA. That's them on top of that. We don't want to mess the ERB as much. Now, also want to say too as well that your ERAs, just like your calcium channel blockers as well, they improve exercise capacity as well as symptoms, as well as your functional class deterioration, and also slow down disease progression as well. Now, though the ERAs had predogenic effects, and they should be avoided in pregnancy, know that enrollment in the REMS program is required for all ages in this class. Do you guys know what a REMS program that is by chance? Good deal. So all these patients, so if they were on any of these ages for the ERA class, they definitely be enrolled to a REMS program. Now we also have our nitric oxide, and our CGMP enhancers. Know that agents in this group, they do increase reduction of your NO as well as your CGMP, which leads to pulmonary artery vasodilation and to a lesser extent your systemic vasodilation. Know that it is accomplished by either stimulation of the SGC, which will increase the CGMP, which you want, and also increase the NO, which you also want, or it prevents the degradation of CGMP by blocking that PDE5 enzyme as well. So that way allows that to produce more CGMP to create that PA vasodilation that we want. So our PDE5 inhibitors, that will include only 2 medications in this class. That will include sildenafil, which is Revastia, the brand name for that, and tadalafil, which is androsterone. So like I would say from the cost standpoint we were talking about earlier, where your calcium blockers being the most affordable, your PDE5 inhibitors in your next class would be the second most affordable. And then from there it just kind of drops at the point where everything's all very expensive. Now we also have your guanylate cyclase stimulant, which is Sigwat. So that is also there is also used too as well, and that requires a RAMS as well too for enrollment. And know that this class also, as suggested earlier, with the ERAs and calcium blockers, they improve the exercise capacity, also improve symptoms, functional class deterioration as well, and slows down disease progression. Now, for our prostacyclin analogs and or prostacyclin receptor agonists. The agents in this group, they produce that potent PA vasodilation, as well as inhibiting that platelet aggregation too as well, and also have both cytoprotective and antiproliferative benefits. So I don't know if you guys remember while I was talking about the pathophysiology for PAH, remember I was talking about different ways how the pulmonary artery can close up. So remember I was talking about how the cells can multiply at that point too as well. The thrombosis, from the damage with the pressure, and the artery can actually start closing up that arterial walls as well. This is where the class can really help with that on that end. More so, definitely more so to be getting more to our final class 3 with poor prognosis and 4 as well. So this is actually accomplished by either stimulating your PR to increase the production of your prostacyclin, or increasing the amount of the PGI2 to your prostacyclin in this case in the body by mimicking endogenous prostacyclin. So we also have your oral prostacyclin receptor agonist, which is Lexapag. So remember what I mentioned earlier, Lexapag, you can on that chart we're talking about that wasn't on there. Remember that you can use it for class 2 and class 2 as well as for class 3 without poor prognosis. Now we also have your prostacyclin analogs, which will include your epoprostenol, which is a continuous IV drip. So it's a pump that the patient will be on pretty much their entire life from that point. As well as your treprostinil, which can give it given through numerous different ways. You can give it as a continuous IV piggyback drip, like a pump, as well as a sub-Q drip too as well. It can be given as an inhaled dry powder or a solution through the vaso inhalation system, and also given as tablets too as well. So with that, what I want to explain too is that the vaso inhalation system is pretty much a portable nebulized device that can be used at home or outside. So they're very specially formulated just to give a specific dose based on what the patient will be getting. And so it, and as the price suggests, it'll be pretty expensive too. Now we also have the iloprost. So your iloprost, that wasn't on that chart, but I want you guys to have in mind that the iloprost can be used for FC3 with or without poor prognosis, as well as for FC4. So that's something you guys should have that down there too as well. Now I know that iloprost, it is given inhaled using the INEB ADD system. So the INEB the ADD system is similar to the Tabasco system as well, where it's pretty much like a battery-powered pulmonary drug delivery system, where it uses a mist, so that way it makes it possible for the patient to take it in easier, and also they can use that anywhere they go. So they can use it at home, where they're at work, or wherever they're at that point. Now, probably next year I'll probably have pictures of those devices. I think it'd be good to see what it looks like. So Now, as far as what they do from a business standpoint, so similar to what we talked about with the ERAs and with our CGMP, enhancements to as well, and our calcium blockers, they improve exercise capacity, symptoms, functional class deterioration, slow disease progression. But here's the thing I outlined here that would be good for you guys to know, is that it does reduce mortality risk, but that only applies to epoprostenol and your IPA patients. So this is actually, so epoprostenol, which is had to be when it comes to the parental standpoint, is most patients are actually on this due to this reason. So if we found a patient, going back to the indication statement we're talking about, if we found a patient has IPAH and they had to be FC4, now we know that we had to put on a parental agent. Epoprostenol is when you probably want to aim for first because there's a mortality benefit to it as well. So that and as long as they have IPAH, of course. So that's another thing. You should know that too. All right. Did you guys have an email lecture too? Anemia, y'all have one? What? On the third? Okay. All right, good. I gotta say what we'll do, so I'm not supposed to call. So, sorry, I'm on the moment. So, okay. So, for anemia and iron status, this is actually extremely common in these patients for PEH. On the end, usually iron deficiency is extremely common. I want to say about, if we're talking numbers, at least 4% of these patients are usually iron deficient. So once a PEH diagnosis is made, we definitely got to screen them for their iron store to see if they're also anemic as well, iron deficiency anemia. And the reason why it's so important because we got to screen them monthly for it, and it's associated with impaired myocardial function, as well as aggravated PH symptoms and increased mortality risk. So there are areas pharmacists we gotta jump into as well and make it do as well. Which a lot of times because usually your pulmonologists are generally ones who are from a diagnosis standpoint are dealing with these patients, and iron therapy is not so much of their forte, but for us, that is our forte. So that's something we had to keep an eye on too as well. Now, know that for anemia, it's usually defined as a serum ferritin of less than 100, as well as transfer saturation or TSAT of less than 20%, as you guys are aware. Now, for your PO iron, that's something that definitely is required if iron deficiency is confirmed, and that will actually add to with that going into our IV iron infusion. So on this end, with iron infusion is only recommended if these patients are either having hemoglobin less than 8, or a patient cannot tolerate PO iron at all due to GI side effects. Now, let me ask you guys this question: as I mentioned here, hemoglobin less than 8. Why do you guys think we have that measure there for IV iron? Why not higher than that? Why not lower than that? Nobody go at once. So so if hemoglobin less than 8, why do we want to use IV iron instead of why we want to use IV iron instead of PO iron?
Because you wanted systemic
circulation.
Okay, all right. So that's one reason, which I agree with. Anyone else? So how many of you work in hospital right now? Okay. Have you guys hear about when we usually get blood transfusions? Market cutoff. So when we get a blood transfusion in the hospital setting, of course we look at the hemoglobin to see if they qualify for that. Usually if the hemoglobin is less than 7, that's when we usually start giving our PRBCs or a red blood cell transfusion at that point, blood in this case. Now we're going to say less than 8 because if it's less than 8, they're definitely in between at 7 to 8 at the very least, so we're trying to prevent them from having a blood transfusion. So that's why it's very important we use an IV iron at that point, because that pure iron will, as we know, it will take time for it to work. At that point, versus IV iron will go right there immediately and start doing what it do. Because as you guys are aware, when it comes to treating anemia, it's not a quick disease where it reverses quickly. It takes time. So if you can cut that time as much as you can, especially based on what the presentation the patient has, that's when IV iron will come into play. So with that, know that pure iron can be initiated if IV therapy has been completed if there's no prior GI intolerance. So for example, let's say we like, on your, you guys had your anemia lecture. Do y'all talk about how to calculate iron stores?
Yeah.
Yeah. All right. So let's say, for example, they need about. Let's say they need about maybe like let's make it simple. Let's say they need about 125 milligrams of iron. And we said, okay, so we're gonna do that. But their hemoglobin was also 7. So, and they have never took pure iron before, so they don't have that prior GI intolerance issue. So it's okay. It lets us say we need to go ahead and start treating it right now, so that way the iron can catch up and help with their hemoglobin as well and reverse anemia. So we get a one-time dose of, let's say, Ferlicet, which is usually becomes as you can do. We usually in hospitals we usually do 125 milligrams for IV infusion, but we also cut those in half really. And maybe because we just want make sure the patient can tolerate it well, we're gonna do half of it. So do half of it, and it's okay now. So we did half of it. We're gonna do PR iron as iron for them to keep taking at home, and they can follow with us within the next month or two, just to see how they're tolerating and check their iron stores again on that point. So there's something that can be done to these patients, which happens quite a bit, especially if cost is the issue, because iron infusion, any type of infusion given outside the hospital, that's cost too. They're already spending a lot of money on their medication they're taking right now from a pH standpoint, and their business as well, and the tests they have to do. So now, as a pharmacist, you're thinking, okay, how can I save this patient money so they can still keep their medication they really take for their PAH? This is an option how you can go about that, as far as starting IV therapy first and go into your PO iron supplementation, which we know PO iron is pretty cheap. Now, know that it will take at least 2 weeks to see improvement in the hemoglobin as well. And also know that your ferritin and your T-stat will take at least 3 to 4 weeks for it to improve. Now, side effects and drug interactions. All right, your CCBs, we have your hypotension as obviously a side effect as well. Orthostasis. Yeah, because we know what orthostasis is by chance? Good, cool. So orthostasis is also a side effect we're seeing, and you see that quite a bit in the hospital too. Generally speaking, for your calcium blockers, to give you guys a brief example, for me, where I work in Methodist, like in a church care pharmacist, I actually work in an observation unit. So it's a short stay unit, where a short stay med surg unit, where basically you stay on average of maybe like 1 to 3 days, more so than 1 to 2 days really on that range. And if I had put a list of the top 10 things which come in into that unit, is due to syncope. And with syncope, we'll try to see, okay, let's get orthostasis done to see if they're positive or not. And that's important because if they're positive, then we know that we gotta look at the medication to see. Mostly it's due to medication induced, and your calcium blockers are usually on that list. So usually I already stopping that agent, or we're adjusting the dosage at that point, or switching to something else completely different. That will usually help manage that for you as well. We also have your peripheral edema, which is dose dependent. Now, like let me ask you guys a question real quick. So with peripheral edema, can you use diuretics to manage that?
You said there it is?
Yes.
Yes.
And so show of hands, yes or no?
Yeah.
So show of hands, no.
What's the trick?
Sound like half y'all don't want to answer. I was like, so
You know, amyloidopathy. That's what you're saying, that's what's one of the causes for peripheral edema.
So with peripheral edema, so the answer to that question is like, it's actually a no.
Because you're using the amyloidopathy.
So this is a good way to talk about this too, 'cause I think we give you guys to know about this. Your calcium channel blockers, we know peripheral edema, or more so that ankle, leg swelling that facial experience, so you can see in the arms too in some rare cases. That's so like the mechanism, or at least what we've seen so far with the study, is that what happens is that with that vasodilation, there's a capillary leakage that goes right at where that blood, where that volume, plasma volume in this case, is going outside the vasculature, but it's going into to your intestinum, which is pretty much outside of your cells at that point. So the reason why it's important enough for your calcium channel blockers, because that's our reach for your diuretics that will push the fluid out. So your diuretics, they're pushing the intravasculature, which is pretty much your veins, your arteries at that point. So when those vein arteries get congested at that point, then yes, you're pushing fluid out at that point, and it'll be received and able to get out, which we already know through urine on our hand. But while since for your calcium blockers, that leakage goes in between your cells, it's very hard to reach that standpoint. So like there's actually a lot of reasons why you see a lot of polypharmacy, especially even with, I've caught cardiologists in this too, where they will try to put a patient on. I remember a couple years ago, I had a cardiologist that actually was trying to give amlodipine 20 milligrams a day for hypertension, and his thought was, oh, patient, I can use hydrochlorothiazide and push the fluid out and help him out. But I explained that it's not gonna do any good for them, because all you're really doing is putting a risk for adverse effects, and that patient was hypokalemic. This is that reason we had to stop it. So that's all I want you guys to be aware about that too. So if you guys see where patients getting amlodipine, for example, because I think calcium blockers get this little what's the best way to describe it? They get a signal with these prescribers saying, oh, it's calcium blocker, it's safe, they won't have any issues. No, they can do this damage that any other class would, if not more. So if you see a patient who's getting amlodipine, and you see them also getting hydrochlorothiazide or even getting furosemide or any loop diuretic, for example, and if you don't see an indication for heart failure, or you don't see anything that's that is shows signs of hypervolemia in that patient, you may want to ask that question and say, hey, why are you taking this? At that point, they say, oh, they're doing my swelling from my amlodipine. That's when you need to go ahead and get that stopped at that point, because it's not really helping that patient, and you just put a risk for adverse effects. And these patients got enough going on as it is. The last thing you want to do is actually want to put a diuretic on board to compromise them on that end. But anybody understand that process? All right, cool. So that being said, peripheral edema is more so happens with amlodipine and nifedipine, and also know that you see less so for diltiazem. So that being said, switching to diltiazem and or reducing the dosage of amlodipine or amphetamine will reverse the edema as well. Know that when we talked about earlier about the myocardium on that standpoint and your dihydropyridines, and what has been seen so far, from a literature standpoint, know that both amphetamine and diltiazem are definitely not HT1 used for a patient who has HFrEF, your heart failure with ejection fraction, because they will reduce the cardiac conductivity, which will lead to clinical deterioration. So that's something to keep in mind if you have a patient who has PEH and also has heart failure due to reduced ejection fraction. you will be aiming for ambulatory for these type of patients at this point because of that reason. Now, we also have our ERAs. First thing to look at is your hepatotoxicity. That's something we did during it when we're trying to evaluate medication to start a patient on. We're definitely checking their liver function too to see how they're doing. So know that bosutin has the highest risk for hepatotoxicity. Then your macitentan is next. Then your abracitinib is last. Now know that only bosutin has the additional REMS monitoring requirement. So bosutin is actually the only one that actually will have two requirements. Besides it being teratogenic, it also will have the hepatotoxicity as an area requirement of REMS. That's something you guys should know too as well. Right there for y'all. So now peripheral edema is also a side effect for your ERAs. You see it more so with bosutin and abracitinib, and you see it at least with macitentan. Now, I'll say this case. Back when we were talking about the peripheral edema and calcium blockers. Now, for them, these can be managed with diuresis because you see more the peripheral edema is more so due to the vascular congestion in the endovascular space. So those you can use diuretics, but only in these very mild cases. So if it's very mild, then you may do a diuretic. If they happen to be hypertension, you may just do hydrochlorothiazide, measure blood pressure, and get some fluid out on that point. I highly doubt you will see us use loop diuretics at that point because that would be just way too aggressive on that end. But if it's more severe on that peripheral edema, then we're looking at just in that dosage like we talked about earlier, or change to a different drug in that class will have less likely to have those peripheral edema side effects on that end. Now, as we talked about earlier, ERAs are also teratogenic, and the REMS program is required, so that we can evaluate risk versus benefits for initiating therapy and monitoring during therapy too. And know that abracitinib has been shown to increase risk for for disease progression and for hospitalization for patients who have idiopathic pulmonary fibrosis. So this kind of goes back to the rationale of use at this point. So if they came in, let's say they had HPAH, which is the heritable PAH due to genetic causes, but they also had pulmonary fibrosis, which is pretty random, but it does happen, then I wouldn't use abracitinib in this patient in this case if we had to use an ERA for them, because of that risk of actually having increased hospitalizations. And it's also because of disease progression, which we're trying not to do that, we're trying to slow down as much as possible, or even halt it. Now macitentan can cause nasopharyngitis, which is about 15%, so that's something to keep in mind too as well. Nasopharyngitis, I mean, with that, that's easily manageable. If that's one thing the patient can be concerned with at that point, we can manage that OTC wise. Provides that bacteria, of course. All right, now we have our NO, CGMP enhancers. So your PDE5 inhibitors, they can cause headaches, GI upset, flushing, muscle and joint pain as well. And we all know PDE5 inhibitors, they're conjugated with and combination therapy with nitrates of any kind. We know this that profound severe hypotension that it can cause on that point. So this is something to keep in mind too for those patients who actually have a history of instability or instability standpoint or unstable angina at that point. There had to be on isotope, for example. Those patients that may have to switch to something else. We're going to start this patient on this type of agent because the blood pressure is going to drop and profoundly at that point too as well. Real Sigwat, the only side effect that's notable for them to be aware about is a syncope, which is important because syncope is also a symptom of the disease as well. So you definitely keep that as something to keep monitoring for too as well for these patients. Know that Sigwat also is a teratogenic, so that's why it's part of the REMS program for it too. And know that a very rare side effect with Sigwat besides that it will be your pulmonary hemorrhage. So if you feel the pulmonary hemorrhage, also we're going to stop the agent and switch to something else. Now we have your PO iron, which is no news for you guys. GI upset, nausea, vomiting, abdominal pain. You also have constipation, dark colored stools. And then for that, how we'll manage that is actually, of course, take with food, then my GI upset, as well as, but if we have to take with food, what we should do, we do give them vitamin C at that point, if they're taking with food at that point, since the food's gonna decrease the absorption of it. And to maintain optimize that drug therapy at that point. Now, for that, on the PO iron, we still recommend vitamin C with it if it's taking an empty stomach, if they don't have those GI related issues, because studies have shown it doesn't really help that much. But if they actually were to, if they were trying to take with food and we're trying to make sure they maintain compliance with it, then fine, also take with food, but also make sure with your food, make sure that it's vitamin C rich, so also drink an orange juice. Or they want to take vitamin C tablets, or they take a multivitamin. I'll just sure that they actually get vitamin C and that multivitamin too as well, and take it at the same time with it. Well, no, I want to take multivitamin because you got to keep separated. So I would say for that one, really just drink an orange juice or keep it vitamin C rich for the food they eat with it, and that will help with it. Now, also too as well, stool softener or bulk flowing laxatives will be important for these patients to help relieve constipation, so to help optimize their compliance. IV iron, the ones you'll see is more so nausea, vomiting, as well as the abdominal pain as well. And the abdominal pain is more so prevalent. You can see that with the iron infusion, especially depending on how high the dosage is as well. Also, and you'll know immediately because once the patient gets that iron infusion, if they have a side effect to it, the first thing they will talk about is the abdominal pain because they describe it as having abdominal cramps. Which if you think about what iron being, how the PO iron having those GI related effects, it's no surprise that IV iron you will experience that pretty quickly. All right, so selection pack. So with that, side effects would be headaches, nausea, vomiting, diarrhea, joint and jaw pain. And we also have your ibuprofen and your treprostinil, the parental formulation. You know, the headache, jaw pain, diarrhea, flushing, hypotension, tachycardia, dizziness, as well as joint pain are all side effects. And believe it or not, these patients tend to experience at least one of these side effects at some point while being managed with these infusions. So there's a lot of titration involved with that too as well. And with that end too, that's why we also have to really be careful that they manage. And usually on our end, from a pharmacy standpoint, we are really managing helping those drips to help them make sure it's in the right infusion and titrate it based upon the symptoms too as what they have too, while maintaining the efficacy for them to make sure that we're getting the benefits they need for them too. So with that being said, since it is parental, on that point, I'll say that it also leads to increased risk of thrombosis, as well as pulmonary malfunction, as well as infection due to being continuously given as a drip. And that includes also the subcutaneous drip for treprostinil too as well. Now for treprostinil, both the PO tablets and as well as the inhalation as well. Now the flushing, nausea, vomiting, diarrhea, abdominal pain, well as headaches, jaw pain, cough, as well as our throat irritation are all side effects you'll see with these with treprostinil through the PO route. Know that treprostinil is a very specific recommendation for the tablets where you have to take with a high-fat meal, which is a minimum of 250 calories, just to minimize the GI upset and increase the drug absorption. So that will be an educated report for that patient when educated about the medication, if they were to get started for the PAH. And lastly, we have our Elprost, which is the side effects associated with this will be with the pulmonary edema, syncope, headaches, flushing, as well as cough, as well as joint pain, hypotension, and nausea. So you see, I see a mention that the pulmonary edema. with that, we do need some medication if they do experience the pulmonary edema that were developed during while they're on this medication, because obviously that's actually going to cause complications, which can push them right into that RV failure, which is what we don't want for the patient. All right, that being said, what question you guys got for me?
Do you have any questions on side effects?
I was like, that's a valid question.
They all sound the same.
I was like, oh. But like, before I go into that, any question about what we just went through it together? Because like, even when explaining what it looked for, you guys still have to understand why you're looking at this. So do you guys have any questions about the path of how this works, as well as why we use these drugs, how we use them, and why we this for each patient?
No question.
All right, good deal. All right, so that being said, I'm going through my bag now, all my questions. I have 12 questions for you guys. So we can start with your question. Side effects, yes. Definitely no side effects lies at that point. So like, I start with our pencil real quick. So the side effect slides, definitely no, because I do have 3 questions about that.
Yeah. Yikes.
So, good question. So 1, 2, 3. I won't say 3 or 4. One's in the case and one's is more so directly asking a question about that. Speaking of the case, there is a case question I have there that will relate to the treatment part here. Go here real quick. So right here, so when I was talking about that big hint to know this,
Yeah.
the case I have, this will help you. Along with what I mentioned about what can be used outside the fact. So the calcium blockers are where it placed at, as well as selective fact too as well. That was something you guys need to know that part to help answer that question. And do have another question is a case, but well, it's not really a case. Is a short case question, but that does involve this slide too as well. I will say for you guys, for the case, I'll be familiar with the diagnostic process with BH. I was like it only because it helped you guys answer that question. Because with it, the way the case flows, you kind of have you want to have a better understanding on why you're choosing that answer. Because if you just go up this slide by itself, it'll be like I can use this, but I don't know why I would choose one over the other. I will say there is a question about the calcium blockers too as well. About that, especially with the vasoactive testing that I was talking about, and how we would manage therapy for them. So that's something that'll be a question on that. I want to say it's on that same case. Now, this slide here, where I was talking about the PA management and follow-up, as well as this slide right here, the process around PH. Definitely know that both slides because they'll put you in a framework to answer the questions I give you guys. So like when I was giving you guys, an example as a pharmacist, you were thinking about rationale, use, so it's appropriate from that end. Is it safe? Is it also cost effective at that standpoint that they can afford it on that end? And which will ultimately lead to compliance, will ultimately will actually benefit the patient. If you go to the thought process of mind and know how to adjust therapies as far as increasing the dosage or change the frequency to eventually get more of the medication, based off efficacy standpoint, and also know when to add a second, third agent, which this slide talks about too as well. That will be key to help answer those questions that I give you guys. I'm trying to see what else. DTPH, that's another area I want you guys to look into as well. The question I have you guys is not a case-based question, but it's more of a do you actually understand what DDPH is and how we will briefly manage that? So this slide will be important. But I think, oh, yes. You guys did mark this slide down too, right? Good. Know that slide too, that's gonna help. Like literally, if you understand this slide, it'll be clear to you by the time you look at the answer, you'll know that the answer will be very obvious to you guys. What the answer will be for that. Plus, as pharmacists, you guys should know this too as well. And I think, as I'm talking, I'm just thinking about what else I'm missing. All right. I will say this: know this class knows what makes this class unique compared to the other classes as far as benefits. I'll leave it at that. And I think that's pretty much. Oh, come back about this. This one too. So more so when you use PO versus IV iron. That's why I asked that question earlier. You guys actually remember why, and we had this, and tried to have a discussion about that. That's why I asked. Well, all right. I think that is pretty much it. At that point, though. So I mean, like, and if you guys got notes on the slides too, and the ones I pretty much like underline, or I put in like underline, for example, on that end. Those are what you guys can know, but also something you keep in mind when you look at the questions too as well. It's very important, I'll help you guys answer it too on that end. And yeah, that's pretty much it, you guys.
Thank you.
Thank you.
Oh, you're welcome, you're welcome.